This lady has oriental cholangiohepatitis. Oriental cholangiohepatitis is a clinical syndrome characterized by progressive cholangitis due to the formation of multiple intraductal pigmented stones resulting in intrahepatic ductal stricturing and obstruction. Because of recurrent cholangitis and their failure to remove her intraductal stones, she had undergone a number of procedures, including a Roux-en-Y biliary diversion to a jejunal limb which lies just below the skin. At the time of this referral, she had had 3 percutaneous drains in place. This drain enters the jejunal limb for access to the choledochojejunal anastomosis. These other 2 drains enter the right and left intrahepatic ducts respectively, passing down through the anastomosis and into the jejunal limb. The cholangioscope was passed first into the jejunal limb in an attempt to visualize the anastomosis. While conceptually a good approach, in practice it was very difficult. While the scope easily entered the limb, air used to insufflate the region simply bubbled away rather than distending the area. Therefore, no stricture could be visualized. Next, the cholangioscope was introduced into the left common bile duct. The bulk of her stone disease is located in the left biliary system, as is typical for this disorder. The cholangioscope visualizes multiple calculi in the left biliary region. Because the anastomosis was found to be widely patent, the cholangioscope is used as a ramrod to push the remaining stones into the jejunal limb without the need of lithotripsy. At the conclusion of this procedure, the 2 other percutaneous drains were removed. She returns 3 months later. The cholangioscope is passed alongside a guide wire threaded into the left biliary drainage tract. The biliary tree appears free of any new stone disease. The drain is replaced into the left system, and she is scheduled to return in 4 to 5 months. While the stimulus for extensive intraductal stone formation is unknown, there is a justified suspicion that an infectious agent is responsible. Oriental cholangiohepatitis is seen almost exclusively in individuals who either inhabit or recently emigrated from regions in Southeast Asia and tends to cluster in areas of lower socioeconomic conditions. The usual lineup of infectious suspects includes the liver flukes, Opisthochus, Clinorchus, and Fasciola, as well as the nematode Ascaris lumbricoides. But there has been no consistent single agent found in affected patients. These patients typically present with recurrent cholangitis, with the therapy being directed towards the removal of the intrahepatic stones. Percutaneous transhepatic management, or ERCP, with or without cholangioscopic assistance, may be successful. Interestingly, the left biliary system is most often affected, perhaps because of the sharper angulation at the level of the bifurcation, which might lead to increased stasis. This angulation also contributes to the increased difficulty encountered in removing these left-sided stones. There is an uncontrolled literature that supports left hepatectomy, demonstrating an encouraging reduction in cholangitis. Theoretically, this approach might also reduce the 5 to 7% incidence of cholangiocarcinoma in this patient population. Surgical diversion and the creation of an hepaticojejunostomy does not alone decrease the incidence of recurrent cholangitis, although the creation of a jejunal limb has been employed to permit easier percutaneous access.